Welcome to the practice on heart anatomy. In this presentation, we'll discuss the structure and the function of the heart. And the purpose of this presentation is for you to understand how your heart works. Did you know that your heart pumps about 100,000 times a day and you don't even need to think about it? It is what we call an involuntary muscle, and you will be amazed at what processes are involved and what we will cover. A resting adult heart pumps anywhere from 3 to 5 liters of blood each minute, and your heart is a muscular organ that is about the size of your fist. So in this presentation, we'll discuss the anatomy of the heart. Heart failure or pump failure is a common heart condition, so we'll explain how the pump actually works. And the pump can actually be affected after a heart attack as well. Valvular disease is a common heart disease, and we'll discuss the valves of the heart. Heart rhythm disturbances are quite common, so we'll take you through an ECG 101 tutorial. We will let you know how the electrical system of the heart is picked up by an electrocardiogram. And if you'd like, we can go into more detail in our ECG tutorial available online. And lastly, we will discuss the fuel lines of the heart. Coronary artery disease results in blockages in the heart, which can of course lead to a heart attack. So let's go into more detail. Here is the anatomy of your heart, and we'll discuss a little bit more detail here now. It is the most important muscle of your whole body. So let's start off by talking about the 4 chambers of the heart. We have the right atrium, the right ventricle, the left atrium, and the left ventricle. Now we'll discuss the blood flow. All the deoxygenated blood comes in from the inferior and superior vena cava, and it goes all the way into the right atrium. Then it goes through the tricuspid valve into the right ventricle. And of course, I'll discuss the valves in a little bit more detail. But once it comes into the right ventricle, it then pumps to the lungs through the pulmonary valve and the pulmonary artery. And it goes all the way to the lungs. Now, a quick Alex Trebek question for you here is the only artery carrying deoxygenated blood is the pulmonary artery. Otherwise, every other artery in your body is carrying fresh oxygenated blood. So once it goes to the lungs to get fresh oxygen, it comes back from the lungs to through the pulmonary vein into the left atrium. Now another Alex Trebek question for you is the only vein carrying fresh oxygenated blood is the pulmonary vein. Otherwise, every other vein in your body is carrying deoxygenated blood. And of course, the only exception to that rule is if that you've had a bypass surgery, then they use a vein. So the vein is now carrying fresh oxygenated point. At that, of course, then that's the only other vein carrying fresh oxygenated blood. Otherwise, it's the pulmonary vein. Then the blood comes through the mitral valve into the left ventricle. The left ventricle then pumps blood to the whole body going through the aortic valve, and it gets pumped out through the whole aorta, delivering oxygenated blood to all your muscles and organs. Now the right side and the left side of the heart work together. The ventricles both pump together, and one pumps to the lungs and the other one pumps to the whole body. It is what we call a crossover system. The blood that was in the right ventricle ends up freshly oxygenated in the left atrium, and the blood that was in the left ventricle ends up in the right atrium deoxygenated. Now, of course, we hear a heart sound, and the heart sound is kind of like a boom boom or a lub dub. Really, what is that sound? Well, it is the sound of our valves opening and closing. The first heart valve sound is the mitral valves and the tricuspid valves closing. And then the next heart sound is the pulmonary valve and aortic valve closing. And that's the bigger one, the bigger heart sound that you actually hear. Now, once you hear that heart sound, the boom boom, the aortic valves are very forceful and the pulmonary valves are very forceful at shutting. And the blood then gets pumped out to the whole body. Now here, let's talk about in a little bit more detail about this crossover system. So here you can see a really good view. The red denotes fresh oxygen travel flow, and the blue denotes deoxygenated travel flow. So let's review this in a little bit more detail. The pulmonary veins deliver fresh oxygenated blood from the lungs to the left atrium, and then goes into the left ventricle to be pumped out to the whole body and organs that require oxygen. The next step is the body, which is the muscles and the organs, use this freshly oxygenated blood and then it gets pumped back to the right atrium, into the right ventricle, and then goes through the pulmonary arteries to the lungs to get fresh oxygenated blood. And the cycle continues again and again. So let's talk about the heart valves. Here we're able to get a cross-sectional view of the heart valves. So if I take your heart and slice it in half, a top and bottom view, this is the view that we're looking at. Each valve has a flap. And looking at the tricuspid valve, you can see it has 3 flaps. The valves between the right atrium and the right ventricle, you can see it has also 3 flaps. Looking at the mitral valve, the valve between the left atrium and the left ventricle, you can see it has 2 flaps. Now the pulmonary and or what we call the pulmonic valve sometimes, is between the right ventricle and the pulmonary artery, and the aortic valve, which is between the left ventricle and the aorta, you can see they also have 3 flaps as well. So let's talk about when valves are not working properly, they fail to open and close like they're supposed to. So there's some causes of valve disease. If they're not able to close properly, then it can become leaky. When it becomes leaky, it starts to pool. And if blood starts to pool, it can result in a risk of clotting. So when a doctor says you have a heart murmur, this means that there may be there is a valve problem, but sometimes murmurs never really amount to much, but sometimes they may. So let's start off by talking about a few valve problems that can occur. You can end up with rheumatic fever. So rheumatic fever leads to a scarring of the heart valves. This scarring can narrow the valve and can make it harder for the valve to open properly or even close properly. In turn, your heart has to work harder to pump blood to the rest of your body. Congenital disease is kind of a born defect. Instead of having 3 flaps, like you see in the above diagram, it only has 2 flaps. This can lead to aortic stenosis, which can be an abnormal narrowing of the aortic valve. It can become significant enough to restrict the blood flow from the left ventricle to the arteries. Heart problems then start to develop. You can also end up with degenerative valve disease. This is a wear and tear on your aortic valve, which can happen in the elderly or even result from calcium buildup. This buildup occurs around the valve itself, causing it harder for it to open and close like it's supposed to. Then you can have endocarditis, which is an infection or inflammation of the heart valves, and this results in the inner lining of the heart chambers, which is called an endocardium. This can be viral-related or even birth-related, and all of this can result in aortic stenosis, which is compromised blood flow from the left ventricle to the aorta. So now let's talk about the electrical system. Your heart beats without you ever having to think about it, and it all starts off with the natural pacemaker of the heart. It is also called the sinoatrial node or the SA node. This node is located in the right atrium of the heart. It sends a signal over to the left atrium, and then the next step actually occurs. So once it sends a signal over to the next door, it then allows for atria to contract, and that's number 2. Then the signal comes down to number 3, which is the gatekeeper of the ventricles, also known as the AV node or the atrioventricular node. Once it reaches the signal, it will then allow for ventricles to contract. And once the ventricles contract, as you can see, the signal goes down the middle of the heart, or the septum in the middle of the heart, and then goes out to each side of the ventricles. Now, all of this can be picked up by an ECG, or an electrocardiogram. And you can see the electrocardiogram is, they stick these stickers on you. Of course, you can see our diagnostics presentation, but the electrocardiogram picks up this electrical signal from your heart. And there are 3 ways in which an electrocardiogram is used. Just quickly, it can be an electrocardiogram on its own just by sitting and resting, a Holter monitor, or a stress or treadmill test. And we'll go over this more detail when we talk about the diagnostic tests. So let's start off by showing one heartbeat and what happens during this one heartbeat. So remember again, it all starts off with the natural pacemaker of the heart. The natural pacemaker, or the SA node, initiates the whole process. It then sends a signal over to the left atrium to contract together. And so it does. And you end up with a P wave, which is atrias contracting. The atrias, or the top 2 chambers of the heart, contract, which results in this P wave on the ECG. Then this signal comes back down to baseline. I will explain this in terms of the baseline in the next slide. but the signal then comes down to the AV node, or the gatekeeper, the ventricles. And then it allows for the ventricles to contract. Now the ventricles are large chambers of the heart. Therefore, it sends a big electrical signal which it denotes the QRS complex. So it comes all the way down the septum and out to the side. Now, it does not always look like this, but it will always be a big spike in the ECG. This big spike is the ventricles contracting. Now, the last blip on the ECG is the T wave. And because the ventricles are such large chambers of the heart, when the ventricles relax, it denotes this with a T wave. Now, people sometimes ask, why doesn't the atria send off electrical signal when they relax? And my answer to this is they are not big chambers like the ventricles, and that's why they relax really inside the QRS complex. So let's talk about baseline. Now, I really want to start off by showing that if there's no electrical activity, this is what your heart looks like. And of course, that's a flat line and not a good thing. This will show us like just no electrical signal. This, of course, like I said, is not a good thing, as there always should be electrical activity. But what I really want you to understand is every time there's electrical activity, it always has to come back to baseline. Now, the reason we show you this slide is so that how every time an ECG has some electrical activity via atria contracting or ventricles contracting or even the ventricles relaxing, it always has to return back to baseline. What we want to ensure at most is that when the ventricles contract, which is the QRS complex, and then they actually relax, which is the T wave, we ideally want to ensure that the ECG signal returns to baseline, as you can see here, before it actually relaxes. If it does not return to baseline, then we start to see some concerns, which is possible ischemia. As discussed in our other presentations, ischemia is a lack of oxygen going to your heart. If there is an area of your heart that is deprived of oxygen, it will show up via an ST segment from contraction to relaxation. This can happen in a heart attack or a possible future heart attack. It shows that the heart is not able to relax like it's supposed to because of an area of ischemia. Now, sometimes there are ST changes that are not significant, meaning it happens because of medications or an underlying arrhythmia, such as left bundle branch block or left ventricular hypertrophy or even right bundle branch block. But either way, this is something that your healthcare team will and should further investigate with further diagnostic tests. A usual course of action will be an abnormal ECG, then go onwards to a stress test, then maybe for a possible perfusion scan, and if that is positive or at risk, then it will send you onwards to an angiogram. Now with an ECG, we are able to see if there are concerns at the top chambers of the heart or in the atrias, or if we see a problem, then it will reflect showing concern in the P wave. Now if there's a problem in the P wave, it could be something such as atrial fibrillation or supraventricular tachycardia. It basically, supraventricular means above the ventricles. And it basically means a problem is above the ventricles. Now the AV node, or the gatekeeper of the ventricles, sits above the ventricles. So if we see a concern in the AV node, we can see that between the P wave and the AV node itself, which is just before the ventricle starts to contract. Now if there's problems in the ventricle, we will see this in the QRS complex. And the QRS complex, it could be wider. Now if we see a problem concern in the ventricles, it could be too wide or too thin, and of course a bigger problem being too wide. Now remember, if you've already been diagnosed with something with a problem either in your atria or ventricles, then you'll be sent off for some further diagnostic testing to see why it is or what concern it is. And of course sent off for a procedure or medications to treat this. And of course you can see our heart diagnostics and our heart procedures presentation. So now let's talk about some common dysrhythmias or irregularities in ECGs. Abnormal heart rhythms can be a problem. So bradycardia is an abnormal heart rhythm in which the heart rate is slow, below 60 beats per minute. Now having a slow heart rate is common in athletes or if you're taking medications such as a beta blocker. But if you're going lower than 50 beats per minute, you could possibly feel a little bit lightheaded. If you have a low heart rate, this is something you can talk to your doctor about. If you have seen, I've seen many patients where they are fine with a low heart rate, and that's okay. but I also seen many patients in which they require further interventions to the point, maybe even requiring a pacemaker. Now, tachycardia is a condition in which your heart rate at rest is too high, usually above 100 beats per minute. If your heart rate is too high, this is putting an increased workload on your heart. And this is sometimes something that should, of course, be investigated further with your healthcare team. Once again, we have seen many patients who are fine with a high heart rate, and of course, others that may require further interventions, possibly in the forms of medication to keep their heart rate or the workload of the heart a little bit lower. Some other common dysrhythmias or arrhythmias are premature atrial contractions, or also known as PACs. And these are extra beats that originate in the upper chambers of the heart, or the atrias. Premature ventricular contractions, or PVCs, are early extra beats beginning in the lower chambers of the heart. Now, if PACs or PVCs are frequent, then this is something to be looked at into further with your healthcare team. But most of the time, there's no symptoms or require no treatment. In some people, it can be related to stress, too much caffeine or nicotine, or even exercise. But sometimes PVCs can be caused by heart disease or electrolyte imbalances. But people who have several PVCs and or symptoms associated with them should be evaluated by a cardiologist. PACs and PVCs can occur with normal hearts during rest or exercise, or they may be markers of underlying cardiac issues. That is why it never hurts to be investigated a little bit further. So again, talk to your healthcare team about that. Some other dysrhythmias that can occur when it is too fast, and if it goes too fast in the atria, you can end up with what we call atrial fibrillation, which is a common heart condition. It is common even in the absence of heart disease. It is really a chaotic atria contracting, and it can occur really sometimes. I've seen a lot of people after heart surgery where this occurs. Atrial flutter, this is not as common, but of course can happen along with atrial fibrillation. Supraventricular tachycardia is where the atria is firing rapidly that the P waves are really hidden. Atrial arrhythmias are not really life-threatening, but should be looked at immediately as they can be with medications, and they can be treated with medications or even procedures. Prolonged atrial arrhythmias need to be looked at as they can lead to clot formation resulting in a heart attack or even a stroke. Now, fast ventricle rhythms are actually life-threatening. This is where you hear on TV and they get the paddles out. Ventricular tachycardia is where the ventricle is contracting too fast. It can happen when you see too many PVCs in a row. And ventricular fibrillation is where the ventricle is chaotic. Again, these rhythms are life-threatening and do require emergent medical care. This can be treated with medications or procedures in which we'll discuss in heart procedures presentation, but at an emergent level, you do require a defibrillator to get you out of that arrhythmia. Here's an example of atrial fibrillation from an ECG perspective. I know it's not easy to see here, but I'll do my best to show exactly what's going on. On the left, you can see a normal heart condition. The signal starts off in the SA node, the natural pacemaker of the heart, then sends a signal over to the left atrium where the atrias contract. Then the signal continues onto the AV node, or what we call the gatekeeper of the ventricles, which then results in ventricular contraction. Now, below you can see a nice regular rhythm. You can see a nice P wave, a QRS complex, and then a T wave. And you can see that very well documented here as a P wave, QRS complex, and a T wave. And you can see that happening very regularly. Well, then on the right, we see an abnormal pathway where the natural pacemaker is not doing its job, which results in a chaotic atria contracting. Some contract normal, where some contract too rapidly, and it is basically what we call fibrillating. And that's not such a good thing, of course. And you can see here that the signal goes down the ventricle, but it is not as strong as it should be, resulting in a reduced contraction times. As you can see, it then results in an irregular heart rhythm below. You can see the QRS complex is not regular, and the P wave is actually notchy, or it's chaotic. Now, Electrical problems you can see here with atrial fibrillation it's not life-threatening, but it definitely should be managed. And one medication that they will put you on most likely is a blood thinner. Most common is warfarin. And the reason for that is to reduce blood clots because the bloods can clot in different chambers of the heart. So some other electrical problems to be concerned about if it goes too slow. And these are more bradycardic conditions. Some conditions where it goes too slow in the atrial ventricles could be a heart block or even an AV block. This is a concern with the AV node or the gatekeeper of the ventricles. This is where the gatekeeper of the ventricles is blocked, resulting in delayed ventricular contraction. And this can be treated with medication or even intervention to a point where the patient may require a pacemaker. Now, a pacemaker kind of acts like a thermostat, where if the heart rate drops too low, then it will kick in and regulate the heart either on the top or below. By the top, I mean the SA node, the natural pacemaker, or below being the AV node, or the gatekeeper of the ventricles. Now, if it goes too slow, then that's when the pacemaker kicks in. So it does not get rid of extra or fast beats, and that's where you require an automated implantable cardioverter defibrillator. Now, a pacemaker, like I said, cannot get rid of the fast beats, so if it goes too fast, you may require what we call this AICD. So if you are at risk of fast rhythms such as ventricular tachycardia or ventricular fibrillation, then an AICD may be an option for you. It is basically inserted in the chest cavity and it will send a shock to your heart or cardiovert it and defibrillate your heart to bring it back to normal heart rhythm. So let's talk about the fuel lines. Heart, like many other muscles in your body, requires a good supply of oxygen to function properly. So there are three major arteries in your body. In your heart. Of course, you got many arteries in your body, but in your heart you have three major ones. The right coronary artery, it supplies blood to the right side of the heart, and the lower and the back side, and the SA node, which is the natural pacemaker of the heart. The right coronary artery feeds the SA node and the natural pacemaker of the heart, therefore regulates the rhythm. Then you have the left coronary artery, and the left coronary artery supplies blood to the left side of the heart. The left coronary artery feeds the pump chambers and may affect circulation. Now it splits off into the other two major arteries of the heart. So it splits off into the left anterior descending artery, which supplies blood to the front left side of the heart, which includes the middle portion of the left and the right ventricles too. And then we have the left circumflex artery. And the left circumflex artery supplies the left side of the heart and down the back. Now collaterals sometimes occur, and the heart has an amazing ability to develop tiny capillaries that produce additional arteries over time. And these are new pathways that branch off the main arteries, which develops with age, exercise, and nutrition. So it kind of forms its natural bypasses or supplies blood to the heart where it's not getting it too much. So let's talk about conditions of the heart in terms of disease. Arterial sclerosis is a chronic disease where the arteries thicken, harden, or lose its elasticity, which then results in reduction in blood circulation. Basically, it's hardening of the arteries. It makes the wall of the artery thick and stiff. Imagine an old garden hose where it is not as flexible as it should be because it's left outside all winter long. That is what arteriosclerosis is. Atherosclerosis is a form of arterial sclerosis which results in plaque buildup of fat in your artery walls, and that's where it restricts blood flow. These plaques can also burst, causing blood clots. Now, going back to our analogy, imagine the garden hose that's been outside all winter. It gets scud buildup in there, which then restricts the water flow, in this term, your blood flow. Now, this happens with increased cholesterol due to inflammation, and it can come from the liver or from your diet. LDL, and I won't get too specific here, we do go more in detail in the risk factor presentation, but LDL, you have different sizes of LDL, and it deposits, the small stuff deposits itself in the arteries of the wall, causing restriction of blood flow. And this can happen in any artery of the body, but it is, of course, managed by exercise, nutrition, and medication, and even stress management. So let's look at an artery here. Here's a quick image of an artery with atherosclerosis obstructing blood flow. And you can see that all the plaque buildup is there. And you can see the only narrowing is that small little area there. And this is what we call a 90% stenosis. So here's a great animation as to what happens during atherosclerosis or plaque buildup. And you can see this is a really good one. So here you have a cross-sectional view of the artery. And this is a nice, healthy, normal artery where we can see right down the tube of it where blood is flowing really, really well. But as we start to get inflammation, the blood vessels thicken, and it starts to have some fatty deposits in there. And you can see now the plaque starts to build up to a point where it's restricting blood flow to a point where you cannot get much blood flow going through there. So that's the process of atherosclerosis. Let's show this from another view as well. And plaque can build up, normally what we just showed you just there, it can build up in the inside of the arterial wall, which is what we just showed you there, which is conventional plaque buildup. And as you can see, this then therefore restricts blood flow. Now the other type of plaque buildup that can occur is contemporary. And contemporary plaque buildup then now starts to occur on the outside. But the good part about this, of course, is that you still get good blood flow. But the concern is that your artery is weaker there, so it can spasm. So the results of plaque buildup can affect your heart, causing, of course, a heart attack. It can also affect the brain, causing a stroke, or even the legs, what we call peripheral vascular disease. So, as said, this can occur in any artery in the body. And of course, if it's going to the brain, then you can end up with a stroke. And if it has happened in the legs, then you can end up with what we call peripheral vascular disease. So transient ischemic attacks, or also known as TIAs, is similar to angina, but it's like a mini stroke without any damage. And it's kind of like a warning sign that a stroke is imminent. Of course, a stroke is similar to a myocardial infarction or a heart attack, but it occurs in the brain. And damage, it can affect different parts of your brain, from paralysis to your senses or even your eyesight. Peripheral vascular disease affects the lower part of your body. Usually patients end up with a cramping sensation where it makes it difficult to walk. The pain at times results in an increased workload on your heart, causing an increased blood pressure and heart rate. Now, cardiovascular disease, the process of atherosclerosis is reversible and it is preventable. Now we focus on our changes that we have to make to reverse the disease process. So thank you for watching this presentation, and we'll see you at the next one.